It's a great honor for me to present first time the interim analysis of registrational trial of triple therapy with boceprevir, pegylated interferon alpha 2b, and ribavirin in Russian patients with genotype 1. And you can see that on behalf of my co-authors, Professor Nikitin, Professor Chulanov, Professor Ogurtsov, Ekaterina Lukyanova, Jay Long, and Fan Helmond, this abstract you can find in a Congress book. It's first time published in this event during the White Nights of Hepatology. What is it? Was the study? It was randomized, placebo-controlled, multi-center, double-blind study of boceprevir combined with pegylated interferon and ribavirin. We included both types of patients, naive patients and the treatment failure patients. Like in a registrational trial that were used for the registration boceprevir and talaprevir in United States and the European Medical Agency. We enrolled 237 subjects, and they were randomized in a 2-to-1 ratio of experimental and the control arm. Patients received open label pegylated interferon alpha 2b, ribavirin, weight-based dose for 4 weeks as a lead-in phase of the treatment, and then the addition of boceprevir 800 milligrams 3 times a day, or placebo for the control arm. Randomization stratified by following factors like interleukin 28B genotype, CC versus non-CC alleles, previous treatment naive patients versus treatment experienced patients, and we had approximately 60% treatment naive and 40% experienced patients enrolled into the analysis. The primary efficacy endpoint of the achievement of SVR was week 24, but this interim analysis was performed for the submission, for the registration in Russia, when all subjects have completed at least week 8 of the therapy or have discontinued study treatment due to other reason. Why we should use this endpoint like week 8? If you look carefully at the data that was produced by Sprint and Response study, you can find that the week 8 results, or week 8 viral load, this is a very predictive for SVR in week 24 of the follow-up. And it because week 8 is really one of the surrogate endpoint of the SVR in this kind of patients. What it was the design of this study? You see that we have the two arms, one for treatment naive and another one for treatment experienced patients. You see that, of course, both subgroups of patients, they have the lead-in phase, and then they received a combination of boceprevir, pegylated interferon, and ribavirin for 24 weeks, and according to the data of week 24, they stratified for continuing pegylated interferons, ribavirin for week 20, or just for following up. In experienced patients, we use week 20, week 12, and also for the stratification between the group with the same kind of design. It's interesting that we have the control arm, and even the control arm in which we use only placebo and pegylated interferon and ribavirin, if we, on the control points, week 12 or week 24, found that the patient's failure, double treatment, all the patients moved to crossover arm and reconsidered to be treated with boceprevir combination treatment, showing on this chart. This is all these patients who failed double therapy in a control arm will move to 32 weeks of combination therapy with boceprevir, pegylated interferon, and ribavirin, and based on the week 8 viral load, they also stratified to two groups with a tail of the treatment with pegylated interferon ribavirin during 12 weeks, or just following up for the 24 weeks for the obtaining the SVR. The interim analysis intended to support early regulatory submission to Ministry of Health. No futility or changes to study are expected due to these kind of results. They performed when all enrolled subjects have either completed week 8 or have discontinued at or before week 8, for example, due to dropout from protocol or possibly side effects. And endpoints was evaluated like a proportion of subject with undetectable HCV RNA at week 8, proportion of subject with undetectable HCV RNA at week 4, this is the end of the lead-in phase, and the week 6, it's a week 4 of combination treatment with boceprevir, interferon, and ribavirin, viral log drop at week 4, week 6, and week 8, and safety according with the analysis that we have at this point for all patients. So if we look at the demographic and baseline characteristics, that was in our study was 237 patients, mainly approximately 60% they were male. The mean age, you can see that patients 10 years younger than in a registrational trial that was performed in US and in Europe. Of course, majority of patients, they were whites, 61% treatment naive, 39% treatment experience. We have the patients with CC genotype of interleukin 28B, only 14%. But it's reasonable figure because I would like to remind you that we enrolled not only naive but also relapsed or treatment failure patients from double therapy with pegylated interferon and ribavirin. The baseline viral load was 6 log, a little bit lower than in international trials. The majority of patients, actually except one patient, they were genotype 1B. It's a typical for Russia because we have the very few patients with genotype 1A. Only around 4% of patients with cirrhosis were enrolled in our study, approximately very close to those that was enrolled in the international trials. And the baseline hemoglobin level was 150 gram per liter, also very close to the international studies. Also because our patients were younger, we have the exposure to viral infection, the shorter period, it's mean that was 8.4 years, comparing with 26 years from the population enrolled in a sprint and response trial. What we have, the results at week 8. In the brackets, we showed the combined week 8 results from Sprint 2 and Response 2 studies. In Russian study, we get 87.4% patients at week 4 PCR negative. And in control arm, only 42% achieve such kind of results. So that's 2 times more often the patients achieve negative HCV RNA at this point. In treatment-naive patients, the same figure, 90%. Treatment-experienced patient, 82%. Of course, in patients with CC genotype, both regimen, placebo pegylated interferon and boceprevir pegylated interferon, they were equally effective. But the delta, instead of the figures, different between our study and sprint and response study, but the delta is very close between 2 studies. Boceprevir combination is better for 45% in Russian study and approximately 40% in international trials. So this efficacy is comparable with those that was found in the international trials. If we look at the virological response rate according to the weeks in which we tested, it's week 4, it's the end of the lead-in phase, week 6 and week 8. We can see the same this picture. You can see that both regimen, it's logically were equally effective at weeks 4 because it's double therapy in both arms. It's a lead-in, the same. But from the 6th week, you can see the huge difference between boceprevir arm and the control arm. And in week 8, this is much more difference with the control arm. This is 41% and this is 88%. But it doesn't work, I think. Could you follow the next slide, please? Yes, thank you. The most interesting data was found when we compared the week 4 response in our study and this in a sprint and response pool data. If you look at the data on the Russian study, and you can see what proportion of patients have the less than 1 log drop from baseline. So these patients are not sensitive to interferon and ribavirin, because during the first 4 weeks of treatment, they do not demonstrate the great decline in a viral load. We have in sprint and response was 27% only, but in Russian study we can have 65%. And among them the negative at week 8 was 45%. The much lower proportion was in the same proportion was in international trials, and the similar data we found in a proportion of patients in whom the viral load dropped more than 1 log from the baseline at week 4. Next, please. It doesn't work, I think it's batteries. Yeah. If we look at the viral load at week 8 by previous treatment and interleukin genotype, and form the groups of patients with previous treatment naive, and treatment failure, you can see there's the clear advantage in both of these groups, the RGT RGT combination with boceprevir, 90% and 80% and 82% versus 47 and 33. If you look at the CC genotype, this is equal in CC allele, and a non-CC, CT and TT combined, this is 85% negativity at week 8 in boceprevir group and only 32% in placebo group. But if we combine these two factors with previous treatment and CC, we can see that's a little bit different distribution. Naive and CC, the equal efficacy of both arms. Treatment naive and non-CC, clear advantage of triple therapy, and also treatment failure and non-CC also the clear advantage. The problem is that it's not available data because no one patients come in this regimen treatment failure in CC, because you know that majority of these patients they can be treated before, because it's very difficult to find this combination that the patients have CCLL and treatment failure from the previous PEG-RIBA treatment, because it's highly effective, as you can see from this arm. It's 100% efficacy. So it's practically not possible to find such kind of patients. Next slide, please. If you look at the adverse events, I would like to note that these adverse events not at week 4, or not for week 8 treatment. This is adverse events. They are evaluated in the moment of analysis. So some patients achieve week 8, and some others who begin the treatment earlier during the protocol, they already come to the week 12, 24 even, or even 30. And so this is a combined adverse events just for the moment of the analysis. This is also the mean range of the same adverse events in a sprint and respond to studies. And if you look that we have the predictable, we have the higher number of patients with anemia, comparing with placebo group in boceprevir arm, a little bit higher leukopenia and neutropenia, very slightly, a little bit, I think it's not statistically significant, the diarrhea, nausea, influenza-like symptoms and dysphagia. This is predictable because these adverse events, they are associated with boceprevir treatment also. Next slide, please. If you look at the grade of these adverse events, if you look for the very low hemoglobin levels, it's practically, we have no patients with hemoglobin lower than 65, not in one arm. We have only one patient with hemoglobin between 65 and 79, and majority of patients, there will be grade 1. The hemoglobin higher of 95 at lower than 109. Why? Because I think they were young patients, the very few patients with cirrhosis, and because its compliance was very good in this study. So I can tell that these patients, from their anemia point, is easy to treat patients with not have the very severe anemia that need to be highly corrected. That you listen lecture today that dedicated especially to correction of anemia in such patients. We also have the neutropenia, and also you can see that's a very few patients with a high grade of neutropenia, and majority of patients also were located in a grade 0 and grade 1. Next slide, please. This is very interesting because you know that in the registrational trial that used for the registration in US and EMEA, erythropoietin used in 40% of patients. Actually, because this is an interim analysis, it's not a real. Can you move it back? Yes. It's not a real data that we will have by the end of the treatment, but in any case, you can see on the moment of the analysis, we have only 8% of patients used erythropoietin. So we are waiting that much lower number of patients will use erythropoietin in our study. But finally, we can tell you about this during the autumn, when practically all the patients they finish the protocol. But if you look at the previous trials, international one, Sprint 2 and Respond, more than 40% of patients in boceprevir arm, they are used erythropoietin. Next. Yes, and one of the last slide, this is a normalization of ILT. You know that we still use this parameter to evaluate the efficacy. Actually, the real efficacy for the antiviral drugs, it's a viral load. If you have virus or not, this is a point of efficacy, but sometimes you need to correct your treatment when you look also to the ALT. And if you look on this data between placebo arm and RGT arm, you can see that those patients who had the elevated ILT at the beginning of the study, at the baseline point, after 8 weeks of the moment of the analysis, 93% of them in boceprevir arm have a normal ILT level, and the same was also in those arm in which just pegylated interferon and ribavirin was used. So that if you have the antiviral efficacy in the treatment regimen, you have to await the clear result also in the ALT. This is a parallel process. When you suppress the virus, the ALT will normalize independently of what drug combination you use. It should be effective. Thank you. And as a safety summary, I can tell that The treatment adverse events were noted frequently in all arms. When we use in clinical trials, you fixed all adverse events, and you can see that's a double therapy and a triple therapy. Majority of patients have any or some side effects. Adverse events that lead to discontinuation of the treatment on the moment of the analysis, of course, were 3% in the RGT arm that used boceprevir and 1.3% in the control arm, so it's just a few percent until now. The reason for discontinuation in the boceprevir arm were different. There was a dyspnea, dermatitis, osteomyelitis, transient ischemic attack, and intravertebral disc protrusion. So that's sometimes you can, difficult to say, is all of these adverse events related with the treatment? Some may be like a dermatitis or transient ischemic attack if it's older patients or patients with some cardiac pathology. But intervertebral disc protrusion, definitely it's hardly to believe that it's related with the treatment that we used. Serious adverse events were reported in a 5% in RGT arm and the same 5% in the control arm. The most common serious adverse events were neutropenia, and you can see that in a table when we talked about the hematological adverse events, 2.5% in RGT arm and 2.6% in the control arm. And I think that's a clear influence of interferon. Some patients there demonstrated very low neutropenia, and I think that this is problems of sensitivity of the bone marrow to interferons. The adverse events that lead to those modifications were registered in 45% in RGT arm and in 16% for the control arm. It's obviously because anemia was noted much more often in the boceprevir arms than in the control arm, so it's not surprising that we correct anemia more often in a boceprevir arms than in control one. And no deaths were reported so far during this treatment phase. And in conclusion, ladies and gentlemen, based on week 8 data, the response rates to boceprevir, pegylated interferon, and ribavirin arm appeared to be significantly higher, 87% versus 42% than in pegylated interferon arm. The main difference between this study and the previous phase 3 studies is a difference in demographics, which predicts a larger response of the patient in this study. The treatment difference between these both arms, however, is similar between studies. It's approximately delta is a 42%. The safety profile of boceprevir pegylated interferon treatment in the Russian study is similar that observed in the previous studies. And I would like to thank everybody, and many of you are sitting in this hall, who participate in this study and enroll patients and still continue to treat them in this protocol. Thank you very much for all of you.